lung injury. And those are outstanding presenters, as I mentioned. And I'm going to introduce the first one, which will be Dr. Fatima Paruk. Fatima Paruk is actually the treasurer of the World Federation, and she will give us a little perspectives on the Africa region. So without delay, Fatima, this is yours now.
Thank you, Javier, for that introduction. Hello, everyone. It really is a pleasure to be part of this event this morning, afternoon, or evening, wherever you may be. I really have no disclosures relevant to this presentation. So if we look at healthcare across Africa, the reality is that it is extremely diverse. Granted, there are pockets of excellence, and there certainly have been innovations of note from a healthcare perspective emanating from Africa. But overall, the healthcare system across Africa is indeed very wanting. If we look at ARDS on the African continent, there has been significant work done in terms of trying to improve the recognition of the disease, or rather the syndrome, largely through modification of the diagnostic criteria through the Kigali modification and the global definition. But the unfortunate reality is that these modifications really haven't made a dent to the outcome. Part of the reason why outcomes are generally poor on the African continent in relation to ARDS is really because of certain unique considerations in Africa. A large proportion of the etiology of ARDS is driven by unique infections like malaria, TB, dengue. The trauma epidemic and the obstetric morbidity, which is excessively high, are also key drivers of ARDS on the African continent. Interestingly, our patients are much younger than in the global north. And in addition, often a fair number of our patients have concomitant HIV, tuberculosis, or even poor nutritional status. Access to healthcare is a huge problem. And as a result, there's delayed presentations and greater severity of disease. In terms of the diagnosis, the unfortunate reality is recognition of disease, despite the modifications of the definition, still remains a problem. Paucity of continuous electricity, the lack of availability of ICU beds, basic equipment like mechanical ventilators, oxygen supply, and essential drugs also feed the problem. And the unfortunate reality is there's a huge paucity of local data to feed local solutions. However, in the last decade, there has been some work done in terms of African data in the critical care context, as well as in the context of ARDS. A few years ago, we published the ACOS trial, which was prospective and looked at 10 African countries and included 64 hospitals and just over 3,000 patients. The vast majority of our critical care patients across Africa are young. About 14% of the institutions did not have continuous or any oximetry. Proning uptake is exceptionally poor and largely underutilized. And basic life support like renal replacement therapy is only present in about 2/3 of the institutions. This explains the high mortality in comparison to the global north. And we attributed this high mortality to insufficient resources and additionally the lack of ICU beds, 1 in 2 patients not being granted admission to ICU. More recently, we took part in the Acute study as Acute investigators This spanned 22 countries, 180 hospitals, and just over 18,000 patients. Primarily, what the study looked at was patients in the wards outside the ICU. Patients were young, median age of 40. 1 in 8 ward patients were critically ill. But what was really staggering was that close to half of the patients did not receive oxygen for respiratory dysfunction or fluids or vasopressors for first circulatory support, and more than half of the patients had no access to essential emergency or critical care. It was no surprise that 1 in 5 of these patients had died by day 7. In the last 5 years, there's been a lot of work done as well in the domain of acute hypoxemic respiratory failure, as well as ARDS. A fair number of these studies have emanated from Uganda through the group of Arthur Kwizera. I've pulled the key messages from these trials together, and the basic summary is that ARDS is grossly underdiagnosed. Even when the definition, the modified Kigali definition, has been met, only 17% of clinicians diagnosed ARDS. And despite the underdiagnosis, the ARDS prevalence is higher than in the global north. Patients are younger. The etiologies revolve around infections and trauma, and mortality is staggeringly high. What clearly comes out is that access to essential emergency and critical care is poor. ICU beds are a problem. Cardiorespiratory monitoring is highly lacking, and limited access to drugs and basic requirements like oxygens and mechanical ventilators is a prevailing problem. Additionally, there's huge room for improvement from a clinical knowledge perspective. In the main, mechanical ventilation is not used that much because of its lack of availability, and it's no surprise that outcomes are poor, either due to delayed utilization of mechanical ventilation or greater severity of illness, alternatively, poor ventilation strategies. Proning is grossly underutilized, and also worrying is that antimicrobial therapy is largely empiric rather than directed therapy. These insights from this data certainly point towards genuine opportunities for us to make a material difference in ARDS outcomes on the African continent. There certainly are rapid gains to be made if we were to identify high-impact, low-cost priorities, be it in the domain of early recognition, the provision of essential emergency critical care, appropriate lung ventilation strategies, proning of patients where feasible and safe, and the aggressive management of sepsis, including source control. I believe key collaborations through academic institutions, public-private partnerships, world and regional societies like WFICC, WHO, the Africa Sepsis Alliance, could be very key in enabling oxygen delivery, the provision of simple pulse oximetry, supply chain management, and the basic consumables by advocating for their need to key stakeholders. Capacity can be certainly upscaled through the provision of education and clinical enablement through bundles, guideline training, the use of telemedicine and remote mentorship. Telemedicine can be very easily used. I remember during COVID, we had a partnership with Charité University, and it was tremendously useful for us because our waves of COVID always followed the COVID waves that started off in Europe. And for us to navigate the period of uncertainty was made much easier through our telemedicine collaboration. And this is something that can be very easily implemented. Certainly, target setting and tracking through the use of simple metrics to monitor progress would be key. And I really think that Africa needs a minimum data set that is agreed upon so that we can have a proper registry, so that we can have data to find our own local solutions. In the interim, can we, obviously these steps do require time, can we manage ARDS in Africa at the bedside in a personalized manner? And I believe the answer is absolutely yes. We really need to improve, to support educational initiatives in terms of highlighting the method of identifying patients who have severe hypoxemia, so that the management can be more nuanced in terms of the optimization of PEEP, the earlier proning, the deeper sedation, the use of or consideration of neuromuscular blockade, as opposed to the patient who has mild hypoxemia, where one has a more restrained approach. Identification of the patient with stiff lungs or low compliance, so that the respiratory mechanics can be better monitored and managed. Fluid management can be more nuanced as opposed to the patient who has a high lung compliance. In a similar vein, enabling the clinicians and the nurses to be able to prone, when indicated in a safe manner, be able to implement low-cost right heart protection strategies and to use fluids and vasopressors judiciously would be hugely beneficial in terms of making an impact on ARDS outcome, not forgetting, of course, sepsis management, including aggressive source control. The patient's trajectory can be used to personalize therapy, evaluating the cardiorespiratory response within 24 hours and 24 to 48 hours to identify non-responders, and then seek out what the problem is. Is there a need for proning? Is there a need to up the PEEP or reduce it? Alter fluid management. Is there missed sepsis or missed pulmonary complications? Would really make a material difference in terms of earlier and timely implementation of appropriate management and certainly alter outcomes. I believe that these practical tips, together with the use of checklists, guidelines, case discussions, be it local or enabled through telemedicine support or WhatsApp or social media support, and even the use of virtual workshops, can really make a tangible difference to ARDS, which currently is a huge problem on the African continent, but certainly is not an insurmountable problem. Thank you for your attention.
Thank you so much, Fatima. It's been an excellent overview entirely from the entire South and Central Africa region. And I think it will be prone for questions at the end of the session, so stay tuned for a little bit. We have the second presenter, Dr. Ashraf Elhoufi. Dr. Ashraf Elhoufi is actually a new head of the intensive care unit at Al Sahara Hospital. And it's a new job for him, but he's been with us for a long time, expert pulmonologist and critical care specialist in Emirates, where he obviously is working. And I would like to introduce him. He's going to give us a perspective of the Northern Africa and Middle East region and the management of a critically lung injury. Thank you, Ashraf.
Thank you very much, Khafir, for the introduction. And thank you, Fatma. That was really an impressive presentation. I hope I will be able to cope up with that. I will just take a different direction because I will be talking about a case presentation. I will just take from the last slide, which Fatma presented about the importance of showing what experience we are facing and how we can learn and lessons from this problem. I will just present a short case which we faced in Dubai Hospital before I move out of it. And he was a difficult case, but luckily we did have a favorable outcome and we did have some lessons to learn from this. That's a young Indian male who lives and works in Dubai. Apparently, he is healthy. He is a non-smoker. He has no comorbidities at all. He presented to the emergency department with a short history of progressive shortness of breath and dry cough. 2 days before that, he did have a flu-like symptoms, and he took some symptomatic treatment from after visiting a private clinic. But he also gave us a very peculiar history that was very strange for us, that 2 days back, he was exposed to an aerosols of a very corrosive material he used to clear a clogged drain in his bathroom. And he closed the door because he has a 3-month-old just baby born 3 months ago. And this formula was very concentrated to the extent that it caused melting of the plastic draining pipe below the sink. We asked him and his wife from where they got this material. He thought that one of his friends, who's apparently familiar with the chemicals, had prepared it to him. So he did not use a commercial formula to do this. That was his X-ray by the day he arrived, and just notice the date, it was October 6th. And since his condition was relatively not that severe, he was vitally stable, he was moderately tachypnic, his saturation even on room air was 95%, so he was admitted in the high dependency unit under the medical team care. His lab investigation showed that he has influenza A by PCR, so we actually don't know what he is suffering from is a viral pneumonia or it's just a chemical pneumonia from the exposure to this corrosive material. His CRP was quite elevated, but his PCT was very low. The rest of his investigation was near normal. The medical team started him on cefotriaxone, azithromycin, as well as oseltamivir. Unfortunately, in the very next day, his condition deteriorated. He was referred to ICU because of increasing respiratory distress, and he became quite hypoxic. His saturation was barely reaching 90%. He was started on non-rebreathing hard flow oxygen mask, then on high flow nasal cannula with a high setting really, which was almost 100% oxygen and 60 liter, and he was shifted to the medical ICU. As expected, few hours later, he got intubated because of further desaturation and increasing respiratory distress. That was his X-ray, and notice again, this is within 24 hours of the previous one after getting intubation with an increasing
Después de la intubación, que estaba aumentando el infiltrado de manera bilateral, como vemos acá. Muchos ajustes ventilatorios se hicieron o del ventilador para tratar de mejorar la oxigenación y evitar el próximo paso. Entonces le pusimos a PCMV, que es control de volumen con una curva de presión desacelerada para evitar el trauma volumétrico. Pero desafortunadamente en cuestión de 1 hora dio como resultado una elevación peligrosa del dióxido de carbono hasta 95 milímetros de mercurio. A pesar de todos los estudios, seguía hipóxico, hipercápnico, acidótico.
A trial of proning, a try to save, if that lung is to be saved, was terminated only after 1 hour because he was dangerously desaturating. So in 1 hour time after supining him back, we decided to put him on VV ECMO. As you can see, that is the X-ray just before putting him on ECMO. And this is the X-ray by the time the ECMO was installed. You can see that his X-ray is progressively deteriorating. In 48 hours, it became completely white, as you can see. Repeated procalcitonin, and this is an important one because this is one of the lessons which I will talk about later, was extremely low. It's still 0.05. The pneumonia panel showed by multiplex PCR influenza A, but there was no bacterial growth. So I decided to stop the antibiotic. Everybody was worried because of that. How come you stop antibiotic in severe ARDS with that such deteriorating X-ray? Of course, you know the trend of using the antibiotic during the COVID. everybody was increasingly using antibiotics simply because the X-ray was deteriorating without any evidence of bacterial infection. On ECMO, we managed to put the patient on a form of ultra protective lung ventilation with a plateau pressure of no more than 20 on a PEEP of 10 to make a driving pressure of less than 13. And the generating tidal volume by this setting was less than 100. This means his lung compliance was extremely low. Despite of this, by adjusting the parameters on the ECMO, the gas exchange was satisfactory. And you can see his X-ray after 7 days on ECMO on day 14, how much it was. It was extremely white, no chance you can see anything in this lung, but we were still hoping. He remained stable vitally with maintained laboratory markers within normal limits. One important point that we did an echo because we didn't want to be fooled by, for example, some sort of cardiac dysfunction, which is causing to us some cardiogenic pulmonary edema, but his cardiac functions were fairly maintained normal, and his NT-proBNP was normal as well. We noticed that the story will become long, so 10 days on ECMO, we did a bedside percutaneous tracheostomy, which was done successfully, and we stopped the heparin during this 6 hours before the process. On October 28, and that was the first time he developed some sort of infection, he developed a catheter-associated urinary tract infection with an ESBL coli, and it was treated with ertapenem for 7 days. Patient condition was stable, but we noticed that there is no evidence of recovery. We are already going to almost 8 weeks while the patient is on the ECMO with no signs of recovery. So we decided to see what is going on. And you can see the extent of damage which happened to that patient lung, and that was already 4 weeks on ECMO. We decided that because of this very slow rate of recovery, that maybe this lung is not meant to recover. Maybe this patient will not have any functional ability for that lung. So we contacted our lung transplant center in Abu Dhabi. And despite they accepted the case on clinical basis that he is young, healthy, no comorbidities, and it is a recent with no associated organ dysfunction, and it looks like the lung is not recovering. So they accepted the case on clinical basis, but there was a lots of other problems, including logistics, admin, and financial issues because there was no insurance coverage. So after a long discussion with them, it was already 8 weeks on ECMO, and that was his CT scan after 8 weeks. By that time, we decided between us that no matter what we will do, apparently this lung will not recover. It's worth mentioning that few days after the tracheostomy, we started to decrease the sedation and the man was quite awake. Yes, we tolerated some degree of tachypnea, which was sometimes distressing to some of our ICU doctors to start him on some sedations again, but we allowing him to participate in a spontaneous breathing with the assisted ventilation. On December 22, which is 10 weeks after ECMO, the patient started to show remarkably some improvement. We actually don't know what happened, but suddenly his lung compliance started to improve, which reached up to 25. The tidal volume started to become 250. So we repeated the X-ray, and to our surprise, that was his X-ray. You still notice the tracheostomy, you notice the ECMO cannulas, but this lung is not the same lung which you saw it last week on our patient. In 2 days' time, while the patient is awake, he helps us very much, and we managed to decannulate him, and he went to OT because the femoral site required some vascular surgery repair, and the high-resolution CT scan, which repeated after that, showed something which we would never expect. That is not the lung which we showed. That was 80 days after this problem did start, and we really don't know how this patient did improve. That was his X-ray after decannulation and removing the tracheostomy and discharging him from ICU, and that was his X-ray when we sent him home. What is important messages which I'd like to say here, The first one is do not lose hope. ARDS is a very unpredictable disease, or you can call syndrome, and we will never expect what kind of recovery a patient can do. After 80 days on ECMO, we thought that this patient has no chance. And if he will not be a candidate for lung transplant, then all what we will do, we will keep on going from one complication to another complication till one of them will be the end of his story. But at the same time, he's young, he was healthy, no comorbidities, no organ dysfunction. So my message is do not lose hope because it is unpredictable. The second thing, don't rush, because if you try to push things which is specific treatment, we actually have no specific treatment for ARDS. I don't know what can I do to improve a lung which looked like that after 80 days on ECMO. We don't have any specific treatment, so do not rush, because anything you will try to do, it might increase the damage unnecessarily. And so the next message is don't push. Too many people are trying to push the ventilator to more traumatic parameters, trying to achieve some oxygenation. Remember, whatever you can achieve from benefit on short term, it will result in a long-term harm. So do not borrow trauma, volume trauma, atelectotrauma, your lung, in trying to improve some sort of oxygenation, because that's not going to go. Time is part of the treatment, so be patient. Do not over-sedate your ARDS patient. Mostly we are afraid that a hypoxic patient will keep on fighting the ventilator, so we keep on deeply sedating them. And if you don't allow the patient to spontaneously breathe and participate in the ventilatory process, you will not be able. The lung knows its normal physiology. Once the patient starts to breathe, he will start to adjust himself much, much better than the way we try to adjust the ventilator. My next lesson is be careful with antibiotics. A white lung, ARDS, is not an indication for an antibiotic. If you start an antibiotic upon suspicion, but then you don't have an evidence of infection, please stop the antibiotic. Worsening, abnormal X-ray, or becoming more white is not an indication to start or an indication to change an antibiotic. Do not increase the problem of bacterial resistance by starting or escalating or adding and changing antibiotics unnecessarily. My last message is really the underlying etiology of this ARDS. So if you ask me, what was the cause of the ARDS? Is it influenza pneumonia? Is it a corrosive exposure and this is a chemical pneumonia? Actually, we don't care much, because there is no specific treatment for neither this nor that. Yeah, and oseltamivir was started after 3 days. Well, we know the oseltamivir effect on influenza is of a limited value, and it is more limited if you start it after 48 hours of the infection. And then the progression of the disease for 80 days was telling to me that the virus was not the primary cause of the problem. So the underlying cause of ARDS might not be that important. It is your supportive measures and the practice of a safe, protective medicine what will give such a patient a chance. And lastly, don't really lose hope, because we don't know what can happen to such a patient. And thank you very much for listening.
Dr. Elhoufi, thank you so much for an excellent, outstanding presentation. So as I say to Dr. Paruk, I'm sure that we will entertain some questions at the end of the session. So stay tuned on the background. And also, I'd like to remind the audience that they're free to post any questions on the chat, and we will be answering some of them shortly. After our last presenter, who is eagerly waiting there, Dr. Young Suh is actually a great collaborator of the Wolf Federation. He was past treasurer. He was also past council member, and now he is definitely helping us in multiple of the tasks that we carry over. He is a part of the staff and actually head of the department of the Samsung Hospital in Seoul, Korea, and he will give us a perspective of that region of the world. Please, your turn. Thank you.
Thank you for the nice introduction. I will share my slides. Good evening, ladies and gentlemen. It's a great honor to speak.
Sí, señores, es un placer para mí participar.
Today, I will discuss lung injury and ARDS in the Asian region, focusing on the epidemiology, clinical practices, and challenges specific to our part of the world. My name is Young Suh, and I'm from Samsung Medical Center, as Javier just alluded to. I have no conflict of interest on this topic. Asia is the most populous continent, home to nearly 60% of the world's population. It is also a very externally heterogeneous region with vast differences in ethnicity, religion, culture, income, and resources. And compared to Europe and Americas, there is a paucity of data. This map shows the distribution of world population with the size of the country representing the size of their population. As you can see, the Asian countries have big graphic representation with more than half of the world population, with China and India leading this trend. Wait, that is not good. Okay, this is a map showing gross domestic product per capita, with darker color having the higher GDP and lighter tone lower GDP. If we focus in the Asian region, you can see that there is a very diverse GDP distribution, with some countries with over 50,000 US dollars per capita and other countries with less than 1,000 US dollars per capita. So there's a very diverse distribution of income among this region. This slide shows the sub-analysis of the famous Lung Safe study, which was a worldwide study on ARDS, which demonstrates how mortality differs across countries when stratified by geo-economic status. Asia contributed significantly to this data set, though outcomes varied greatly between high-income countries and middle-income countries. This reinforces the need to interpret Asian data within the context of socio-economic diversity. Another important factor determining management practices and outcomes of acute lung injury in ARDS patient is ICU resources. This map depicts the number of ICU beds per 100,000 people, with darker color representing less ICU resources beds. As you can see, the Asia region, there is a very diverse distribution with many areas of darker red color, which signifies scarce ICU beds per population. This study, published by the Asian Critical Care Trials Group in 2024, also highlight the diversity in ICU resources in our region. This graph compares the ICU beds per 100,000 population in 19 countries of Asia. Although, it compares the ICU beds capacity before and after COVID-19. Although in many countries, experience of COVID-19 was an impetus to increase ICU beds, there is more than 30 times difference capacity to care for the critically ill among countries involved in this study. How many patients suffer from ARDS in Asian countries? These are some of the studies on that subject. The first study from Taiwan, which was analysis of their national insurance data, shows that the incidence of ARDS increased from 2.5 to around 20 from 1997 to 2011, while the mortality decreased. A study with similar design from South Korea, which was also analysis of our national insurance data, show that about 5 incident cases of ARDS was per 100,000 population, and the hospital mortality was around 33.7%. Singapore study, which was a population-based prospective study, showed a similar incidence of ARDS with higher mortality. And a multi-center study from China showed that from 18 ICUs in the mainland China, showed that ARDS patients comprise around 3.6% of total ICU admissions, and they had a mortality of 40%. Regional multi-center projects such as FEPIMCTI study and IMPROVE study also provide valuable insight, and these 2 studies will be explored in more detail later in my talk. Despite methodological differences, these studies suggest that ARDS incidence in Asia is broadly similar to that of European countries. This is an interesting study in which the investigators in Singapore prospectively collected data on incident ARDS for 1 month in all major public hospitals in Singapore. As you know, Singapore has a very good public health care system in which they provide care for most of the critically ill patients in Singapore. During that period, there was a total of 15 ARDS patients, which was used to calculate the incidence per population per year. Causes of ARDS was mostly pneumonia, with significant proportion of patients receiving tidal volume of more than 8 milliliters of kg of predicted body weight, which is the upper limit of the recommended tidal volume. The incidence shown in this Singaporean study, which was adjusted for population 5.8, which was similar to studies done in Europe. For example, the Alien study, which is in the third column, but it was lower than the studies from USA and Australia. For example, the Lee study, which shows that the incidence is 38.3 per 100,000, and so on. For Rubenstein study, it's 64.0, and for Australian study was around close to 30. But for European study, it was very, very similar. And an ARDS mortality in our region seems to be decreasing. As you can see, this is the Taiwanese study, which shows decreasing trend of ARDS mortality from 1997 to 2011. And Korean data also shows a trend for low mortality as the years pass by from 2010 to 2019. Now, let's look take a closer look at the two multi-center studies from our region. The PREVENT IMIC study was a prospective observational study from 54 ICUs from 10 middle-income countries in Asia-Pacific area. Study period was from November 2017 to December 2018, in which they prospectively collected patients for all ventilated patients from these ICUs, which was 1,015 patients, and out of them, 89 patients had ARDS. The 89 was 6.8% of mechanically ventilated patients were ARDS, and ARDS patients were younger than non-ARDS patients. They had higher SOFA score, and interestingly, 11% of all ventilated patients came to the ICU after being ventilated in the general ward, suggesting there was a very limitation of resources in these regions. ARDS patients received lower tidal volume with a median 7 milliliters per kg per predicted body weight compared to non-ARDS patients, and significant amount of patients, but significant amount of proportion of patients received tidal volumes that was higher than the recommended in the guidelines. PEEP was higher in the ARDS patients compared to non-ARDS patients, as was blood pressure and driving pressure. About 40% received neuromuscular blockers, and 6% of ARDS received prone positioning, which is slightly lower than what Young Suh study of the worldwide ARDS study, epidemiology study. The IMPROVE study was a multi-center cross-sectional study conducted on November 4th, 2019 in 190 ICUs in 17 Asian countries, in which they collected data on 1,408 mechanically ventilated patients that was on that day. And among them, 138 patients had ARDS, which comes out to 9.8% of all ventilated patients. So the age of ARDS patients was around 60. 63% were male, and PF ratio was around 212, which was lower than non-ARDS patients. And most of the, more than half of the patients were on pressure-limited breaths, either pressure support, pressure control, or SIMV with the pressure control. This is the ventilator parameters and adjunctive treatments done on these patients. As you can see, the tidal volumes were around 7.3, blood pressure 22, PEEP of 7.8. And significant amount of patients, 40%, around close to 40% of the patients were receiving steroids. 11.6% were on neuromuscular blockers, and 8.7% of ARDS patients received prone positioning. And mortality was 36.8% in this study. This is the distribution of tidal volume the patient received in the IMPROVE study for total ARDS and non-ARDS patients. And even for ARDS patients, around 30% of ARDS patients was receiving tidal volumes higher than 8 milliliters per predicted body weight, which is the upper limit of the tidal volumes, suggesting that there is still a need to get the evidence out there, and a lot of people are not still following the recommended tidal volumes. This table compares the 3 studies, a lung safe study, which is the worldwide study, and 2 studies from Asian regions. The PREVENT-IMIC study is from 10 middle-income countries, and IMPROVE study is from 17 countries, Asian regions, but about half of them are from high-income countries. The incidence of ARDS was 23.4% of mechanically ventilated patients in the lung safe study, but for the Asian studies, it was lower than the worldwide study of lung safe, or 6.8% for PREVENT-IMIC and 9.8% for IMPROVE study. Tidal volumes was similar, maybe slightly lower in PREVENT-IMIC study. Plateau pressure was higher in PREVENT-IMIC study compared to 2 other studies, maybe in part due to higher PEEP. Driving pressure was around 15% for all studies. The use of neuromuscular blockers was highest in the PREVENT-IMIC study, while lung safe study had 20%, and IMPROVE study was around 11.6%. Prone positioning was slightly lower in the PREVENT-IMIC study, and steroid use was much higher in the IMPROVE study compared to lung safe study. So there's a very variable use of these adjunctive therapies in the 3 studies that is shown here. In our region, we also have guidelines on ARDS. For example, the Japanese guideline, this is the latest version of the Japanese guideline, published in 2022, but the guideline was made in 2021. And also, we have a second version of the Korean guideline, which is not yet published, but was announced at our meeting in April of this year. When we compare the regional guideline from Korea, Japan with the ATS and ESICM guidelines, all 4 guidelines strongly recommend lower tidal volumes. And all 4 guidelines either strongly recommend or conditionally recommend prone positioning in moderate to severe ARDS. The Korean and Japanese guidelines mention limiting plateau pressure and driving pressure with conditional recommendations. For PEEP, 4 guidelines differ slightly, with the Korea and ESICM saying that they cannot recommend either higher PEEP approach or lower PEEP approach. But for Japan and ATS guidelines, there is a conditional recommendation for higher PEEP use, especially for moderate to severe ARDS. 3 guidelines mention about respiratory maneuver. 2, the ATS and ESICM say strong recommendation against, while Japanese guidelines have a conditional recommend against. For neuromuscular blockers, 3 guidelines said conditional recommendations in early ARDS, but ESICM guidelines states that they do not recommend routine use of neuromuscular blockers. For steroid, the Japanese guidelines strongly recommend low-dose steroids, while the Japanese and Korean and ATS guideline has conditional recommendation for their use. ECMO, there's a general favorable recommendations, slightly stronger for ESICM guidelines. So Asia is a very heterogeneous area with huge geo-economic variation among countries. The incidence of ARDS in Asia is similar for that reported in European countries. Compliance of lung protective strategy is similar to that reported in other regions. but limited resources and in manpower and equipment may hinder delivery of optimal treatment in some countries. More data from our region is really needed. Thank you for your attention and muchas gracias.
Thank you so much, G.S., with an excellent overview of the actual situation in the Asian continent. We do have some questions. I think we have about 10 more minutes to respond to those, and I will also invite any additional questions to come to the chat. Please, if you have anything, just write it there, and we will be able to answer. So I'm going to try to divide this to one particular person on the panel. So I'm going to go and distribute the first one to Fatima. Fatima, this is a question coming from Carolina Aguilera Chavarria, who's asking about the education at a distance. So virtual education, how is that valuable for respiratory specialists? And I'm understanding this is more for the respiratory therapies, kinesiologists, and compared to physicians, of course. And also, if you can a little bit give us a perspective of, do you think all African countries share the same problematics? I think you already mentioned most of that on your talk, but if you just want to summarize that, and that's the questions from Carolina Aguilera.
Great question. So it relates to remote learning, am I correct?
Yes.
Yeah, so remote learning when it comes to respiratory therapies is very interesting because it offers really a very attractive opportunity to reach out remotely. What has been found, however, is that it depends in terms of its success in terms of the level of the individual you're reaching out to. If it's an individual who needs hands-on experience, who needs to be walked through the initial understanding of the basics of resuscitation and so forth, that kind of teaching actually necessitates physical on-site teaching. So perhaps you can then use a blended kind of training where you may have a hybrid technique, some physical on-site, and the rest can relate to remote training. But in cases of individuals who already have a basic understanding of medicine, resuscitation, respiratory techniques, in that situation, certainly remote training has a huge role to reach out, particularly in countries like Africa, where everything is very remote. You have one individual 50 k's away, another one 500 k's away. It's difficult to go to every site, and in those situations, it makes a huge difference. The second question related to, is the terrain equal? Absolutely not. Within each country, between countries, extremely variable. I work in South Africa, and all our university hospitals, state-of-the-art equipment. Most of us can practice ECMO. And then 500 kilometers away from us, huge problems with electricity and basic supplies. So extremely variable, ranging from state-of-the-art to really a huge paucity of resources. Thanks.
Thank you. Okay, I'm back. I think I have a little bit of a misconnection for a second. Thank you, Fatima, for the answer. But let's get the next question, which is a very interesting question for Dr. Elhoufi. Ashraf, it's a question also divided in two options for you. One is obviously ECMO patients had, this is coming from Marcela del Rosario. And Marcela is asking, obviously ECMO patients had an indication of limited mobilization. You know, they need to be kind of quiet, right? And there's significant problems with cannulation, etc. So how do you take that into our experience and our guidelines of mobilizing patients? That's a number one question. And then I think the other thing again is related to it. How do you manage the ECMO patients along with the daily spontaneous awakening trials and sedation holidays on those patients? How do you cope with that?
Yeah, the first one related to the mobility or early mobility of ECMO patients. Initially, when we started to deal with ECMO, you look at the catheters and you become scared because the cannulas are very big and you feel that it will tear the veins apart. But later on, we realized that that's not true. And we started to wake up the patients, and the patients are awake. And once they know that there is a machine which is supporting their oxygenation, their irritability and excitability become much less. And we're doing that on a regular basis. And to tell you the truth, what triggered that was our lung transplant center refused adamantly to take any patient who is not functional, sitting and even standing and walking on ECMO. So that pushed us that if you have any chance to help your patient, you have to stop the sedation, allow some sort of mobility. The nursing care will be a little bit more difficult, but whenever we do the physiotherapy, our perfusionist also is always there, and we need to keep the patient awake, participating on spontaneous effort on the ventilator, and passive and active cycling and sitting on the edge of the bed, standing, it becoming now a must. Otherwise, this patient will always lose his muscle mass, or later on, if he require a lung transplant, they will say he is not in a good functional capacity to perform a 9 to 12 hour long surgery because he will not be in a good functional state. So we have to do that. So initially, when we dealt with ECMO, something like 15 to 20 years ago, we were really scared. We deeply sedate most of our patients. And we end up with sedation-related problem, which is actually more than the problems which we have from the awake patient. The second thing, the ventilator. Most of our doctors are scared whenever they find the patient becoming tachypnic. It's normal. A patient is having a very low lung compliance and he cannot stretch his lung, so he will feel that he has to breathe more, even if his oxygenation is good. You have to tolerate that because most of the doctors, who are particularly the junior doctors in ICU, the first thing they will do, they will sedate the patient again. Now we have a better sedation protocols. The longer acting sedations need to be stopped. Shorter acting sedation need to be done. The term sedation break, I don't usually accept it very much, the term of daily sedation break, because we really have to decrease the sedation level to allow the patient to be awake and to actively participate while he's on the ventilator and ECMO. That patient stayed on ECMO 90 days. If I keep the patient sedated for 90 days, I don't know if he will ever wake up later on with any kind of functional capacity. So yes, rehabilitation, early mobility, stop sedation, allow the patient to actively participate, and I will not miss also the active nutrition. I always consider that nutrition is one of the important parts of patient's management in ICU. It's not an ancillary measure which need to be taken care of. They lose muscle mass, and if you lose the muscle, you cannot wean the patient from the ventilator.
Fantastic. Well, thank you, Dr. Elhoufi. Very, very eloquent answer. And I want to give the credit to the last portion of the question to Alejandro Castro, who was the one that really posted this question on the chat. And the last, but not the least, for you, G, this is coming from Javier Ramirez Ospina. And it's an interesting question regarding our actual management of patients with ARDS. Everything we've done, every add-on therapy that we have done, including the ARDS net, had really yielded us somewhere between 30 to 40% mortality. There's still a very elevated mortality. And we could say this is the nature of the beast, but is there anything we're missing? And one specific question that Javier is asking you is something regarding the airway pressure that we are missing as a variable on our patients. What do you think about it?
Well, the question is a very interesting question, but in my point, the ALDS is a syndrome, so it is not a specific disease with a specific mechanism that we can intervene, and there's no specific therapy so far. But I think the reason I now explain to my juniors that the lung was designed by the forces that we don't control for maximum diffusion. It's an organ that they can maximize diffusion. So it's very vulnerable to outside mechanical forces. So maybe in the future, when we have other ways of oxygenation, making gas exchange better or more portability, maybe we can decrease the pressures that we put on our vulnerable lungs. Maybe in that way we can prevent war. Now we are trying to do it with this very, in some way, crude machines, but maybe we can find ways to make gas exchange more safer extracorporeally, and maybe we can prevent ventilator-induced lung injury that way. Another part is the subphenotype. Many people may be more vulnerable to A intervention, some people will be more prone to respond to B intervention. If we can find ways to sort out which patient will benefit from which treatment, we will find more outcome of our ALDS patients. I hope that answers that question.
It's an excellent answer. You gave it the two perspectives, the old perspective, and it made me remind, I remember partial liquid ventilation and the trials with partial liquid ventilation, obviously, in an advanced fashion. And second is phenotyping, so precision medicine along the line in the future. So I think that is an excellent a compromise really for the future. Thank you. I would like to thank the three speakers, the panelists here today. G particularly is in the early hours in the morning, and I know it's very difficult. Thank you so much for joining. Not that the other two are and much better. I know your time is very valuable, and I really thank you. There have been excellent presentations. This is the World Day for the critical lung, and this is definitely a representation of the entire world that we have here today. So I thank you, and I thank you, the audience, for their stamina of being here with us, and I will invite them to continue. This is the last portion of the session. We're going to finish now, but the entire program continues. So stay tuned. There will be more interesting things to come. And thank you again. Goodbye to everybody.
Bye.